Good morning. I'd like to welcome you all to the Medicine Mind the Gap lecture series organized by the Office of Disease Prevention. Our Mind the Gap lecture series is a series that explores issues at the intersection of research, evidence, and clinical practice. We hope with this seminar series that we engage the NIH community in thought-provoking discussions to challenge what we think we know and to think critically about our role in today's research environment. We're webcast today, so when you ask questions, we ask that you please ask them at one of the microphones so that the folks on webcast can hear the questions. For those of you viewing on webcast, please feel free to submit your questions via Twitter using the hashtag NIHMTG, and please always make sure to follow us at NIH Prevents. We're also happy to accept questions via email at prevention@mail.nih.gov. I'd be remiss if we didn't thank our co-sponsor for today's lecture, the National Institute on Alcohol Abuse and Alcoholism. And with that, I'd like to turn the mic over to the Associate Director for Prevention and Director of the Office of Disease Prevention, Dr. David Murray.
Thank you. I'm very happy to be able to introduce our speaker today, Linda Collins. Dr. Collins is Professor of Human Development and Family Studies at Penn State University. She's also Professor of Statistics at Penn State University. She is Director of the Methodology Center at Penn State, which is a well-known group that focuses on prevention and treatment methodology development. She directs a training program in prevention and methodology, and her research interests are in analysis of longitudinal data, particularly latent class approaches. She has a recent book on latent class analysis. And she's going to talk with us today about methods that can be useful in designing trials, drawing on experiences from engineering, which is a different field altogether from most of what we do. I'm often asked, why do we always have to do randomized clinical trials? Why do we have to do these the studies the same way all the time? Aren't there other methods that we can use? So I'm very pleased that Dr. Collins today will be talking about some of the methods that have been developed recently that let us do a better job with the clinical trials that we do. Dr. Collins.
Thank you. Thank you. It's really great to be here, and I'd like to say I hope we have a lot of discussion, so feel free to interrupt me with questions or comments at any point. Okay, the title of my talk today is Raising the Bar, Engineering Optimized Behavioral Interventions for Increased Public Health Impact. I want to start by giving you an outline of my talk. First, let's establish what gap we're minding, because there's different ones we could potentially be minding. I'd like to get a few definitions so that we're all on the same page about a few things. I'll talk about what's business as usual in developing behavioral interventions. Then I'll talk about how one can engineer behavioral interventions using the Multiphase Optimization Strategy, or MOST. I'll discuss the question, does optimization replace evaluation? We'll talk about two fundamental principles that underlie MOST. Okay, so then how do you do this? I'll talk about two examples that are currently in progress of applications of MOST, and then I'll ask you to imagine a few things with me. Okay, so what gap are we minding? Well, every year in the United States, cigarettes cause 443,000 deaths and $193 billion in healthcare costs and loss of productivity. Another 400,000 deaths are attributable to poor diet and physical inactivity. Every year, worldwide, cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes cause 35 million deaths. All of these have important behavioral risk factors. The World Health Organization has estimated that elimination of behavioral risk factors would prevent up to 80% of heart disease, strokes, type 2 diabetes, and over 1/3 of cancers. So behavioral risk factors are very important. So I'm talking about behaviors like alcohol, tobacco, and other drug use, physical inactivity and sedentary behavior, eating poorly, risky sexual behavior, non-compliance with chronic disease regimens and cancer treatment regimens and other disease regimens, and many, many other kinds of behaviors. All of these behaviors can potentially be modified by means of behavioral interventions. So behavioral interventions are potentially very important. So the gap we're minding today is the gap between the importance of the impact of these behavioral factors on public health and the effectiveness of today's behavioral interventions at modifying these factors. And you can probably guess that I believe that behavioral interventions could potentially have a much, much greater impact on public health than they do today. If you only remember one thing from our time together today, I hope it's this: that behavioral interventions can be engineered to meet specific criteria. If we do this, this will set the bar for effectiveness, efficiency, and scalability of behavioral interventions. And then, once we've set a bar, we can keep raising the bar and gradually close this gap that we're talking about today. Okay, a few definitions just to make sure we're all on the same page. Let's start by defining a behavioral intervention. It's a program aimed at modifying behavior for the purpose of treating or preventing disease, promoting health, and/or enhancing well-being. That's the definition of behavioral intervention I'm going to use today. So there's lots and lots of examples. A few are clinic-based smoking cessation interventions, weight loss or weight management programs, and school-based drug abuse prevention. Those are just three out of many, many, many different kinds of behavioral interventions. Now note that according to this definition, most behavioral interventions are packages that are made up of many components. And if there are any physicians here in the room, I know that physicians sometimes use the word intervention the way I'm going to be using the word component today. So it'd be good to keep that in mind. So my definition of intervention component, the components that make up behavioral interventions. Any aspect of an intervention that can be separated out for study. So what is a component is kind of in the eye of the beholder in many ways. So it could be, a component could be a part of intervention content. So maybe you have a drug abuse prevention curriculum, and part of the curriculum is devoted to establishing social norms, appropriate social norms. Maybe part of it is devoted to resistance training. Maybe there's a component aimed at parents. Each of those could be considered a separate component of the intervention. A component also can be a feature that promotes compliance or adherence to the intervention. For example, if the intervention involves taking some kind of medication, you could use a MEMS cap to record when people are actually taking the medication, or at least when they open the bottle. And also, a component can be aimed at improving the fidelity of delivery of an intervention. So for example, an 800 number that program delivery staff can call if they have questions about how to deliver the intervention. These are all examples of intervention components. So intervention components can impact the effectiveness of an intervention, its efficiency, or its economy. Really almost any aspect of an intervention. Some components of a behavioral intervention may be pharmaceutical. I'll be showing you an example later of a smoking cessation intervention where nicotine replacement is one of the components. And of course, components can be defined at any level. Many interventions today are multi-level. So components can be defined at the individual level, the family level, the school level, etc. Okay, business as usual in developing behavioral interventions. How are behavioral interventions mostly developed today? Typically, the intervention components are chosen based on scientific theory, clinical experience, sometimes analyses on data that have been conducted, data analyses conducted prior. There's lots and lots of ways that behavioral intervention components are selected, but typically they're selected a priori, and then they're combined into a treatment package. And then that treatment package is evaluated by means of a standard randomized controlled trial, or RCT. And by randomized controlled trial here, I'm talking about an experiment that is intended to evaluate a behavioral intervention or an intervention of any kind. So typically, there's random assignment to a treatment group and a control group, which is standard of care or some other suitable control group. Typically, there's 2 experimental conditions, usually called arms in an RCT. Sometimes there are 3. It's rare, but it does happen sometimes that there are more than that. This is what I'm going to call the treatment package approach. It's kind of business as usual, as I said, in development of behavioral interventions. So this is kind of a schematic of the treatment package approach. So you have a selection of components. There could be any number of these intervention components. They're combined into a behavioral intervention, and that is then evaluated by means of a standard RCT, as I said before. Now, what's wrong with evaluating a treatment package by means of an RCT? The answer is there's absolutely nothing wrong with that. That's how you should evaluate a treatment package. That's not where my issue is. The RCT is designed to tell us whether a treatment package performs better than a control or a comparison, or whether one treatment package performs better than another. My issue is with what happens right here between components and putting them together for the behavioral intervention. The RCT does not tell us some important things. Suppose you do an RCT and you get a significant effect. It does not tell you which components are making positive contributions to the overall effect. You don't know whether the effect is driven by one component or whether all of the components are contributing to the overall effect. You don't know whether a component's contribution offsets its cost. Now, there are some interventions where all the components cost about the same. Internet-delivered interventions, typically that's the case. But there are lots of other interventions where some components are relatively inexpensive and some are very expensive. And maybe it would be good to know whether those very expensive components are having a correspondingly powerful effect. You don't know, based on an RCT, whether all the components are really needed. You don't know whether you're wasting time, money, materials. And in general, you don't know what to do based on an RCT to make the intervention better, to make it more effective, more efficient, and more scalable. If your RCT is non-significant, that does not tell you some important things too. It doesn't tell you whether any of the components are worth retaining. It could be that you had a non-significant effect overall, but 1 or 2 of the components in there is worth retaining. You don't know whether one component had a negative effect that offset the positive effect of some of the others. And there are some examples of this. There hasn't been a lot of research on individual intervention components so far, but some meta-analyses, like the one I cite here, suggest that sometimes there can be negative effects of individual intervention components. And in general, you don't know specifically what went wrong and how to do it better the next time. Very often when people get a non-significant RCT, it's back to the drawing board. But it's unclear what the next step should be. The treatment package approach, I feel, has encouraged some things that maybe aren't so good in intervention science. One is stuffing the behavioral intervention with many components to get a significant effect. If it's very important to get a significant effect, and of course it is important to evaluate interventions and get a significant effect in an RCT, and you're not worried about economy, there's very little disincentive to add more and more components to the intervention. And of course, we're all taught that to increase statistical power, you need to increase the effect size. So that seems like a reasonable thing to do. The issue I have with that is, think of all the behavioral interventions that are supported by NIH, all the successful ones. How many of those actually go to scale in any meaningful way? And I think one reason why they do not is because they're too big. They're impractical for actual implementation in community settings. The treatment package approach has downplayed considerations that are important: efficiency, cost effectiveness. I never hear people talk about time effectiveness, but I think that's interesting, an interesting concept, because more and more, when you talk to people about scalability, in school settings, in healthcare delivery settings, time is at a premium. And it's just not practical to implement an intervention that takes a long time. And also, I believe we're focusing too much on attaining statistical significance. I want to emphasize that I'm not saying that statistical significance is unimportant, but we're not paying enough attention to meeting clinically meaningful criteria and setting a bar that can be raised. And that's going to be a theme through my talk today, setting a bar, a clear bar, so that we can then keep raising the bar. So what's the alternative? What's the alternative to the treatment package approach? Well, when engineers build products, they take a different approach. Engineers do not use the treatment package approach. They take an approach that's systematic, that's efficient, that husbands research resources, and that's focused on the clear objective of optimizing the product, whatever it is. Not focused on attaining statistical significance, but rather on optimizing the product. So a few years ago, my collaborators and I started wondering, can we borrow ideas from engineering? Can we borrow some ideas from engineers and the way they do things and apply them in the area of behavioral interventions, and then build optimized behavioral interventions? And that's primarily what I'm going to be talking about today. Okay, so engineering behavioral interventions, the multiphase optimization strategy. MOST, which is how I'll abbreviate this, is an engineering-inspired framework for development, optimization, and evaluation. So we're still evaluating here behavioral interventions. And I want to emphasize it's a framework. It's not an off-the-shelf procedure. So because it's a framework, it can be very different in different implementations. But using MOST, you can engineer a behavioral intervention to meet a specific optimization criterion of your choosing. So again, here's the schematic of the treatment package approach that I showed you a minute ago. And so I'm suggesting removing that part and replacing it with this. So in between developing the behavioral intervention or putting together the components into a behavioral intervention, there's empirically based optimization. I'm going to talk some more about what I mean by that, but essentially you conduct an experiment to look at the individual effects of the intervention components. After you've done that, you put the components together in a way that meets the optimization criterion that you've selected. I'm going to talk about optimization criteria some more in just a moment. But notice that here, the box is transparent. And I chose that deliberately because we know what's going on inside the box after we've done this study. We know that it's made up of components that are operating the way we want them to. And then there's evaluation by means of a standard RCT. So optimization, let's think about that for a moment. I use this definition, which comes from the Concise Oxford Dictionary of Mathematics, the process of finding the best possible solution subject to given constraints. And the subject to given constraints part is really important. Optimized does not mean best in an absolute or ideal sense. Very often when we use the word optimized colloquially, that's what we mean. When we say optimal, we really mean best. But actually, the technical use of that term in engineering is a little bit different. I like it because it's realistic. It includes constraints. There are always constraints operating. And I love the idea of being realistic about constraints and saying, how well can we do? What's the best we can do given a realistic set of constraints? So optimization always involves a clearly stated optimization criterion. This is your definition of best possible given constraints. It's a clear goal that you want to achieve. And once that goal is achieved, once you've met an optimization criterion, you've set a bar, and now someone else can come along and raise the bar, or you can raise the bar yourself in your next round of research. So let's talk about a few examples of optimization criteria. So maybe you are simply looking for an efficient intervention with no dead wood. You want an intervention in which there are no inactive components. So consider, for example, a school-based drug abuse prevention program. And suppose you just want to be confident that every component is necessary so that you feel that you're not wasting time and money. Well, you can achieve this by conducting the optimization experiment that I talked about a moment ago, and we're going to go into more detail about that. And based on that, selecting only active intervention components. It's possible to use somewhat more sophisticated optimization criteria. Suppose you're interested in the most effective intervention that can be delivered for less than or equal to some dollar amount. So here, think about going to scale with an intervention. We know that very expensive interventions are not likely to go to scale. So one way to approach this is to find out how much is society willing to pay, how much are insurers willing to pay, how much are school districts willing to pay, whoever is footing the bill, what's a realistic amount of money, and then engineer the best intervention that you can obtain for that amount of, that will not exceed that amount of money to implement. So consider a smoking cessation intervention. Suppose that insurers say that they'll pay for a smoking cessation intervention that costs no more than $500 a person to deliver. So you can achieve this by conducting empirical research that looks at the individual effects of the components and selecting a set that represents the most effective intervention you can get for less than $500 a person. Now this, of course, assumes that you have data on how much each component costs, and you can usually collect that while you're doing the experiment. Suppose you're interested in the most effective intervention that can be delivered in less than or equal to some amount of time. So maybe you're trying to deliver an HIV prevention intervention to MSM in a clinic setting, and there's not a lot of time. So the intervention is going to be delivered by nurses or physicians who have only a few minutes with the patient. So suppose they say, well, we'll give you 6 minutes. That's all the time we have. Well, you can engineer an intervention that's the best you can get for 6 minutes or less. So these are examples of optimization criteria. Cost effectiveness could be an optimization criterion. I'm not a health economist, and I don't have a lot of experience with that, but it would be possible. You can combine criteria, so you could have a criterion based on a combination of cost and time. In cancer treatment, very often there are cognitive issues, and you potentially could optimize an intervention so that it didn't exceed a specified level of cognitive burden. Or any other relevant criterion. Anything that's relevant in any particular situation can easily be stipulated in the optimization criterion. Okay. Oh, yes, Barry.
So when doing this, let's say a single criterion,
Oh, dear, yeah.
So when engineering this as a single criterion, the first example that you gave for a certain level of effectiveness for a certain dollar amount,
Yeah.
can you also engineer it with varying levels of effectiveness for varying dollar levels? I'm thinking of a decision maker or somebody who directs a program or a state office. So you say, I want this level of effectiveness for this amount of money. So can there be a range to be built in?
Yes. Yeah, so I'll talk about this a little bit more later, and if I don't cover it to your satisfaction, please raise the question again. But I would envision that after you conduct the experiment on which you're planning to base the optimization, you could even post the results on the internet. You wouldn't be posting individual subject data. It would just be the results of an analysis of variance, along with any information about cost that you might have collected, although people may know better what the costs are in their own locale. And it would potentially be possible for people to optimize then to a different optimization criterion, yes. that would be kind of a new level of transparency in intervention science that I think would be really healthy. Yes.
Hi, I'm Rick Berzon with the National Institute on Minority Health and Health Disparities. I just have two quick questions about your suppositions. One is, if you're going to make a selection of an intervention, and you're going to engineer it based on what works, I don't understand how you got to the point of knowing what works.
I haven't gotten to that yet. I
okay.
will.
That's great. And then the other question I had was, it sounded like in the example that you used, you're basing on a willingness to pay model, which is offered by the sponsor. But there's a kind of a conflict there, isn't there? If you're asking the sponsor to base a decision on willingness to pay, that doesn't necessarily mean that the intervention is going to work. It just means that you're asking the sponsor to base it on resources, and that basing it on resources that haven't necessarily been proven effective or even efficient doesn't sound like, I don't know how you got to that using that criteria.
Yeah. Okay. I'm not sure I understood the last question, but let me just quickly go over something, and that might answer your question, but if it doesn't, I want to go back to it. So this is where you get the information about what works. You conduct an experiment here, and I'm going to talk about that in a moment. And after you've put together the intervention, you then would evaluate it by means of an RCT. So that would tell you whether the intervention has a statistically significant effect. Is that what you mean by works?
So you're sort of randomly selecting the empirically based optimization intervention?
No, you're conducting, this may become much clearer in a moment, but you'll conduct a randomized experiment here, and based on the results of the experiment, you will get data about which individual components are working.
Oh, all right. So you're going to start with all of them in the first place?
Oh, yes, yes. You start with all of them in the first place. You look at them this way by means of this experiment. And then based on the experiment, you get effect size estimates for each component. You can tell whether components interact with each other. And then based on that information, you can put them together to meet the optimization criterion.
Okay.
Okay, and I'm going to give a couple of examples of this, and if it doesn't clear it up for you, we can come back to it in a little later. Any other questions before I go on? Those were great questions. Okay.
Thanks. You know, I was just curious about how you deal. Oh, I'm up here.
Oh, okay.
Back. Just curious about efficiency. Efficiency. So we want to have efficiency, and it seems like when you develop an intervention, you're doing it in the least efficient way. So the first time you develop it, in fact, it's almost analogous to what people say in the pharmaceutical industry. They say building a new pill is like building a bridge. So all of the investment is getting the bridge up, and then after that, you just collect tolls when people come across.
Yeah.
Well, similarly, building a new pill is like that. You have a lot of upfront investment, but then if you reach a big market, then you can sell the pill at a much lower rate. Similarly, isn't that so with behavioral interventions as well? So if you're doing this by cost, you're optimizing by cost, you just put all this effort into getting it right. When it goes out into clinical practice, we would hope it would be much more efficient than that.
Yeah, that's an interesting point about whether interventions get more efficient when they go out into clinical practice. I'm not sure that's true, actually, but I'd be interested to hear what other people think who have more on-the-ground experience with behavioral interventions than I do. It's sort of widely thought that most interventions become less effective when they go out in the field, so that's that efficacy effectiveness differential. Yeah. And I guess I would call that less efficient if they're being less effective.
Yeah, I used to work on studies where we did cost effectiveness of behavioral and other interventions, and what happens is that when you cost out the intervention in a research study, it's always much more expensive, just because you have staff time.
Oh, I
and a
see.
lot of
So
other
you're
stuff,
saying
yeah.
the cost estimates may not be right. Yes. Yeah, that is probably true. And I guess I have a couple of comments to make about that. One is, if you're thinking in relative terms, at least you would probably know the relative costs of the components. But you're probably right that data that you collect as you go might or might not be valid about cost. And so there might be other ways to do it. For example, talking to people in the settings in which it's going to be delivered and collecting cost data that way. They might have much better ways of costing it out. That's a really good point. Thanks, Bob. Okay, does optimization replace evaluation? I want to make the point here that optimization and evaluation are different. They answer different questions. So we're typically used to thinking in terms of evaluation. This is the question that the RCT is meant to address. Is the intervention's effect statistically significant? We definitely want interventions that have a demonstrated statistically significant effect. Optimization is a different question. The question that optimization poses is the intervention the best possible given constraints? And so I presented this 2x2 table so that you can see that it's possible that you could have an intervention that falls in any of these 4 cells. So for example, maybe the intervention's effect is not statistically significant, but you also have not optimized the intervention. So maybe you want to try optimizing the intervention. You can even use effect size as a criterion, and we can talk about that some more, how you would do that if you are interested later. Maybe the effect is not statistically significant, but you have optimized the intervention. So it's possible to have an optimized intervention that still does not demonstrate a statistically significant effect. And that, to me, suggests that you might need an entirely different intervention strategy. This is where I think we are with most of our evidence-based behavioral interventions today. They've shown a statistically significant effect but have not been optimized. And so they could be made better. They could be made more effective. They could be made more efficient, more cost-effective. There's a lot of things that could be done. And this is what I think we should be aiming for. Behavioral interventions that both have been optimized and have been demonstrated to have a statistically significant effect. So that's the difference between optimization and evaluation. Two fundamental principles. There are 2 fundamental principles that underlie most. The first is the resource management principle. It says that we want to conduct our research in such a way that we get the most scientific information that we can for the amount of money that we have to conduct research. So the idea here is you identify clearly, this is what I need to find out. These are the resources I have or can reasonably obtain. And now, how can I manage my resources strategically to get the most information and the most relevant information given the resources that I have? And you'll see as I go on that sometimes suggests some somewhat different approaches to experimental design than what we might be accustomed to. The second is the continuous optimization principle. No intervention is ever just permanently optimized. When you think about consumer products, over the years they mostly get better, right? So the cars of today are typically more fuel efficient than cars were 20 years ago. Most of the time, if your vacuum cleaner breaks and you go and get a new one, it's going to have more features, it'll be more ergonomic, and so on. So engineers are always revising products to make them better. And I believe we should be doing the same thing with our behavioral interventions. You can always make an intervention better. You can make it more effective. You can try and keep the effectiveness about where it is, but make it cheaper or more efficient. There are always things you should do. There's a tendency now, I think, when we bring an intervention to a randomized clinical trial and it shows a significant effect, we don't want to mess with it. It's like that's the intervention, that's the way it is. And I believe we should always be working on revising behavioral interventions, making them more modern, making them more effective. So those are the two fundamental principles, and you'll see them in action as I go. Okay, so now, how do you do this? So let me show you a couple of in-progress examples that have been funded by NIH. The first one, I think many of you will recognize Bonnie Spring. She's at Northwestern University, a really terrific intervention scientist. I feel lucky to be working with her. The objective here is to develop a highly effective weight reduction program aimed at adults. It's called Opt-in, and it's funded by NIDDK. It was funded quite recently. Here's a theoretical model. There's a core education program that actually has been demonstrated to work already, made up of education, goal setting, skill building, and some technology tools. We are actually looking at components that ultimately are going to affect adherence to the intervention, we hope. And those components are phone coaching. This is the number of sessions, 12 versus 24 sessions we're looking at. Text messages, whether there's communication with a primary care physician. Everyone is going to have a buddy. All the people taking part in the intervention is going to have a named buddy. But the question here is whether they should have buddy training or not, whether the buddy should be trained, and then whether meal replacements are provided or not. These factors are aimed, or components of the intervention are aimed at self-efficacy, self-regulation, supportive accountability, and facilitation. Those are the mediators that we hope will increase adherence that ultimately will lead to weight loss. Yes? No. Yeah. Yeah. Yeah, I'll just repeat the question. The question is, can you explain supportive accountability? It's kind of a neat concept. The idea is that there's someone that you report to, and it's typically the coach, but the buddy serves this role a little bit too. So it's someone that you go to and you tell them what your weight is. And of course, you're supposed to be maintaining or losing weight. And so there is accountability there, but the person is always supportive. It's not a punitive arrangement. The person doesn't make you pay a fine or yell at you or something if you actually are losing weight. Instead, they're supportive and they keep trying to get you to do as well or better. So that's the idea of supportive accountability. Okay, so this is most as it's implemented in opt-in. So these are the 5 components that I showed you a minute ago. We do a component screening experiment, which I'm going to describe in just a moment. The optimization criterion is the most effective intervention we can get that we estimate will cost $500 or less to deliver per person. Once we've optimized the intervention and we get the optimized treatment package, eventually it will be evaluated in an RCT. Okay, so now I want to talk about this, the component screening experiment, because that is, yes?
Linda,
Yeah.
Since this is a real example in
Yeah.
the study that's underway, can you just fill us in on the mechanism that was used to fund it? Is it an R01? Is it?
It's an R01.
Okay.
It's an R01 from NIDDK.
So does the R01 go through the entire
No.
schema here?
It does
or
not.
What part of this does
Yeah.
it cover?
It covers up to the optimization. It does not include the RCT. Yeah, the plan is to apply for funding to do the RCT. Other questions before I go on? Okay, so the component screening experiment. This is very important for optimization. The idea here is to screen intervention components efficiently. We're talking about weeding out the components that are underperforming or not performing. We want to get a sense of the magnitude of each component's effect, and we want to examine whether the effect of a component may be augmented or reduced in the presence of another component. In other words, whether there's interactions between components. And this is the information that we use to optimize the intervention. So any experimental design is a possibility, but the choice of design is really critical. The only requirement in most is that this experimental design be selected based on the resource management principle. So it has to be a design that gives you the most information you can get given the amount of money that you have to spend on it. So the idea here is to select a design. You want to usually consider several and examine the scientific information you would get from each one and whether, of course, whether it's the information you want, and then what each design costs. And the costs usually revolve around the number of subjects, that's a big driving force in cost, and the number of experimental conditions. And I want to point out, the starting point is the resources you have or can reasonably get. So sometimes people ask me, isn't most prohibitively expensive? Well, it isn't, but it isn't by definition, because the idea here is to take a reasonable amount of resources and get the most scientific information that you can out of those resources. So I'm going to go through a few experimental design possibilities here. So one possibility would be to conduct an experiment on each component. So this would be, in this case, 5 separate experiments, kind of like 5 little RCTs. Another approach, and this design is used a lot, this is often called a comparative treatment experiment. So it's very much like running 5 individual experiments, except there's one shared control group. So you would compare 24 coaching so there'd be a condition where there's 24 coaching sessions, all the others are set to low. You compare that to the control group. Text messages are on, all the other components are set to low or off. You compare that to the control group and so on. So there would be, in this case, 6 experimental conditions. So if you compare these two design possibilities, you see that there's some big differences in cost. 2,800 subjects to get the power that you want versus about 1,700 here in the comparative treatment experiment. This also involves fewer experimental conditions. John, do you have a question?
Yeah, I'm getting curious. For any one component, how would you treat a phenotypic interaction term, i.e., one condition will work best for redheads, the other for blondes?
Yeah, that's a great question. And the issues here are the same as they are in a standard RCT. So when I talk about interactions here, I'm talking about interactions between the components that we're looking at. But of course, it often is also important to look at interactions between characteristics of the individual and performance of the intervention components. There's a couple different ways you can handle that. One is you can do exploratory analyses that examine those interactions. Now, sometimes those aren't very well powered, like many exploratory analyses, but they can be very informative. And an advantage of, I haven't gotten to the winning design in the opt-in study yet, but the advantage to designs that enable you to look at the effects of individual intervention components is that you can look at interactions between characteristics of the individual and individual intervention components, and that can be very revealing. If you know a priori that there are going to be important interactions between hair color, as you said, and some intervention components, you can build that into the design. And that can be expensive, but it definitely would give you the most power. Does that answer your question? Okay, the third possibility is the factorial experiment. And for those of you who maybe haven't thought about factorial experiments for a while, here's a very, very quick factorial experiments 101. So suppose you had a 2x2, the classic 2x2 factorial design. There's one component can be either off or on, component A. Second component can be either off or on. And there's 4 experimental conditions. One where they're both off, one where they're both on, and then 2 conditions where one is off and one is on. We're interested here primarily in main effects, although interactions are important too. If you want to look at the main effect of A, you would compare the average of these 2 conditions to the average of those 2 conditions. The average of the conditions where component A is off to the average of the conditions where component A is on. Similarly, if you're interested in looking at the main effect of component B, it would be the average of the two conditions where B is off compared to the average of the two conditions where B is on. There's something very important here I want to point out. In a factorial experiment, all of the subjects are involved in all of the effect estimates. So you notice here, there's a main effect of A that involves all of the subjects in all four conditions. The main effect of B also involves all of the subjects in all four conditions. They're just reshuffled. They're just reshuffled. Factorial experiments can have more than two factors, of course, and I'm going to show you some in a minute. And they also can have more than two levels per factor. Those designs can be expensive, and I usually don't recommend them for component screening experiments. We can talk about that some more if you're interested. So the opt-in study, if we chose to use that design, would be a 2 by 2 by 2 by 2 by 2, or a 2 to the 5th factorial experiment. It would have 32 experimental conditions. How could that ever be powered? Some of you may be thinking. And I'm going to explain that in just a moment. But I do want to point out, and I'll explain more about this, that it would take an N of 560 to power that experiment, even though individual experiments would take 2,800 subjects, and the comparative treatment experiment would take almost 1,700 subjects. So at least in terms of subjects, this factorial experiment is looking very efficient. 32 experimental conditions, though. We felt that we could handle 16 conditions in the field. That was about it. So, is there a possibility here? There is a fourth type of experimental design. It's actually a special case of the factorial experiment called a fractional factorial experiment. In a fractional factorial experiment, a fraction of the experimental conditions are run. Could be half of the conditions, could be a quarter of the conditions, and so on. Fractional factorial experiments are powered exactly the same way as ordinary factorial experiments, but they involve fewer experimental conditions. But there's some important trade-offs that we'll discuss shortly. But now let's compare all four of these possibilities. The two factorial experiments require the fewest subjects by far. And although 16 conditions is a lot, it's half of 32 experimental conditions. So we decided we would go with the fractional factorial experiment. Notice that with individual experiments and the comparative treatment approach, you cannot examine interactions. You can examine all interactions with the full factorial experiment. With a fractional factorial experiment, you can look at selected interactions. Is that you, Denise?
Yes, it is. I just am wondering, when you're talking about power during this whole thing, what outcome you're talking about? This is a weight loss eventually study, but
Yeah.
are you talking about weight loss or some intermediate outcome?
It's weight loss here.
Okay, thank you.
And the N that you're talking about is the total number of participants
Total number of participants.
in the whole show.
In the whole subject and the whole,
So it's not
whole
per
experiment.
it's not per condition.
Definitely not. No, it's across all conditions. Okay, so this is the design for opt-in. Everyone gets that core intervention that I showed you on the slide before. And then these factors are varied. Number of phone coaching sessions, 12 or 24. Communication with a primary care physician, yes or no, and so on. So the overall N, as I said, is 560. That's about 35 per condition. So how can that be sufficiently powered? Let's look at the main effect of number of phone coaching sessions. You would get that by comparing the mean of conditions 1 through 8 versus the mean of conditions 9 through 16. That's based on all 560 subjects. Now let's look at the main effect of PCP communication. The mean of 1 through 4 and 9 through 12 compared to the mean of 5 through 8 and 13 through 16. Again, based on the total N of 560. And it's the same for all 5 main effects, and it's actually the same for any interactions that you look at as well. This is why Fisher invented the factorial experiment and the analysis of variance. This is why. Because factorial experiments are very, very economical in terms of use of experimental subjects. And as I hope I showed you or convinced you a minute ago, much more economical than doing individual experiments on the individual factors. Much, much more economical, at least in terms of number of subjects. But there's no free lunches in statistics, ever. And so there are some trade-offs when you choose to use a factorial experiment, as a fractional factorial experiment, as opposed to a factorial experiment. So what do you gain? Well, by using a fractional factorial experiment in opt-in, we were able to reduce the number of experimental conditions by half, from 32 to 16. Or, put another way, if we decided that we could only handle 16 experimental conditions, we could have looked at 4 factors with a complete factorial. So with a fractional factorial, we were able to look at 5 with 16 experimental conditions. But this is what we give up. Once you start pulling experimental conditions out of a factorial experiment, then certain effects get bundled together, and you can no longer estimate them individually. Certain effects are bundled with certain other effects. Now, the good thing here is that all the fractional factorial designs that exist were figured out by statisticians a long time ago, and it's very easy to look up what effects are bundled with what. And we know in the design we chose exactly which effects are bundled with which other effects. So in the design we chose for opt-in, each main effect is bundled with one 4-way interaction, and each 2-way interaction is bundled with one 3-way interaction. And we know which one it is. It's not just any. We know exactly which one it is. So the logic here is our theoretical model does not predict any large 3-way and 4-way interactions. And I'd be interested if anyone knows of a theoretical model that predicts large 4-way interactions. We felt pretty safe bundling the main effects with 4-way interactions. So if you can assume, if you feel comfortable assuming that those higher order interactions are negligible in size, they don't have to be 0, they just have to be negligible in size, then the idea is that the main effect that you estimate is going to be due primarily to the main effect, not to the 4-way interaction. So you're estimating a bundled effect, it's a main effect and a specific main effect and a specific 4-way interaction, but the 4-way interaction is negligible in size, and so you're assuming that the estimate you get is due primarily to the main effect. So it's a trade-off. So in reality, the higher order effects can be negligible or they could really be large, right? Those are the only 2 alternatives. An effect can be negligible or it can be large enough to worry about. And you can choose a complete factorial design or a fractional factorial design. If the higher order effects really are negligible, a fractional factorial design is the right choice because it moves science forward faster. If you chose a complete factorial, then you would have wasted resources. You could have looked at additional factors. If the higher order effects are really large, though, there is the possibility of some incorrect decisions. Of course, there's always a possibility of some incorrect decisions. But there is an additional possibility of incorrect decisions about component selection. So there's a trade-off here. Sometimes maximizing efficiency calls for taking calculated risks. It's part of the resource management principle. And there are opportunity costs associated with the less risky option. You might be thinking, well, then why don't you just always do a complete factorial? If you can only handle 16 conditions, just do a smaller complete factorial. Well, you certainly could do that. And that might be the right choice many times. But I just want to point out there are opportunity costs there. There's components you would not be investigating if you chose that route. So this is the resource management principle in action. I have a certain amount of resources. I know I can conduct 16 experimental conditions. I have 5 components that I want to look at. What do? Do I give up one component, or do I and conduct a complete factorial, or do I conduct a fractional factorial, make those assumptions about higher order interactions, but that gives me the ability to look at 5 factors. So it's a trade-off. I want to point out, though, that you don't escape that bundling when you use a design like this. A lot of people, I think, don't realize this, but the comparative treatment experiment bundles, for example, the main effect of coaching would be bundled with all of the interactions involving coaching, which actually is more aliasing than there is in the fractional factorial design that I showed you. So, I'm sorry, aliasing is the statistics word for the bundling that I talked about. So there's actually more of this bundling in the comparative treatment experiment. So once you take a complete factorial and you start removing conditions, which is what you have here, this is a subset of the conditions from a complete factorial experiment, you will have some effects combined. It's inevitable. And when you use a fractional factorial design, you know which ones they are. Okay, so let's say we've conducted the experiment, which we haven't started doing yet. But suppose you had the data. You conduct an analysis of variance. That would give you estimates of the effects of each of the components. And you would use this information to select components to include in the intervention. You would discard components that are not performing adequately. You have an estimate of the effect size of each component, and you can combine that with other data if you want to, with cost, or just base your decision on that, and select components that will make up the optimized intervention. Of course, keeping the optimization criterion front and center. So in opt-in, it was just funded this past fall. We're currently finalizing the intervention protocols and the manual of operation, and we expect to start the experiment that I showed you late summer, early fall. So there's no data yet on that study. So after we've optimized and evaluated the intervention, we will have set a bar for weight loss interventions. It will have been optimized to a specific criterion. We'll say it's the most effective we could do that can be delivered for $500 a person or less. So our work will establish which components work. It'll be known which components work. So future work by us, by others, can build on this, and you could develop an intervention that's equally effective but costs less, for example. That could be the optimization criterion. Or more effective. Keep the $500, but try and bump up the effectiveness. But there's a bar there. So it's clear my next intervention, or your next intervention, is going to be better than this in these very specific ways. Or someone might say, well, I don't like your optimization criterion. This is a more meaningful optimization criterion. But that still enables you to compare the performance of the two interventions. This is the continuous optimization principle in action. Just keep optimizing the intervention. Keep raising that bar. David?
Under future work, the third bullet, here's a more meaningful optimization criterion. Is that something that could be applied to the study that you've just done? And
potentially, if you had the data, yes.
Right. So,
yeah.
But if you could do it, because you would have the data, but someone else could do it if they had access to your data.
Yep. That's yeah.
So you're not limited, even though you've done the optimization experiment, you're not limited to the optimization criterion that you started with.
Absolutely
you could
not.
post hoc apply others.
Mm-hmm. Yeah, you definitely could. Yeah, and that's why I'm envisioning that you could put the results of the analysis of variance up online, and someone else could use that, and they could optimize away. Denise?
Hi, yes. Denise from NHLBI. So we have funded studies that have had a program of intervention, but there's a lot of participant interaction with the program deliverer. So, for example, there's a lot of sort of patient-oriented perspective. So that, for example, in this instance, it's a randomized trial, but you might say, here's the entire program. Would you, as an individual participant, like to have a buddy? Mm-hmm. Or would you like to have 12 or 24 phone calls or whatever it is? So it's a program, but the way it's delivered is the way it would be delivered perhaps in clinical practice with some negotiation in a patient-centered way. Mm-hmm. The way you're doing it is extremely interesting, but everybody gets the final package. There's no participant negotiation.
Right, but you could build that in.
So I would be very interested in seeing a comparison
Uh-huh.
of what you end up with here
Uh-huh.
with all the pieces of the program delivered in an individualized, patient-centered way. That's something that, is this issue at all something you all have discussed or thought of?
No, we've kind of had our hands full
Yeah.
just with this, but I think that's really interesting. But Denise, you could certainly do it the way you're suggesting. That is, when you got to the RCT point, there could be another arm that allowed people to select from sort of a cafeteria-style menu of what components they wanted. But you also could do a component screening experiment in which, depending on exactly what the research question is, you could compare, say, assigning the component to allowing people to opt in or out of the component and see what the effect of that was for an individual component. You know, just depending on what your interests are. Yeah, Harold.
So if I'm understanding the continuous optimization principle, I'm assuming that you don't need to have done an optimized experiment on a previous intervention. You could take the continuous optimization principle and apply that to some other intervention that has been tested in the traditional RCT way and implemented and, say, perhaps scaled up. But you could still use this principle to improve it with a new optimization
Yes, absolutely.
method.
Yeah, everything I'm talking about today would apply to an existing intervention if you wanted to break it down into components. Yes.
Isn't the clinical effect size much smaller in the factorial design that you have, as if you're requiring many more subjects in order to show a significant effect, as opposed to testing the individual components and seeing their total effect size, given that the incremental additional clinical effect of an intervention when everybody's on typically maybe 7 other components of an intervention, it's got to be much smaller and harder to show an effect.
Right. Yeah, so it's true that the effect of an individual component is smaller than it would be in a treatment package where all the components are working and pulling in the right direction. That's true. But this example I showed you was powered for I forget now what effect size we use, but maybe 0.3 in that neighborhood. So that's 0.3 of a standard deviation. So it is possible to power experiments appropriately, even though, yes, you would expect that, again, if all the components were having a positive effect and pulling in the right direction and having a detectable effect, then yes, the total would of course have to be larger than any individual component. I also want to mention that when you're powering these studies, typically when we power an experiment that's more for sort of scientific discovery, the first thought is, well, I need to go to the literature and look at what effect size do I expect, you know, is there prior literature on this and so on. And that's certainly a good thing to do in this context too. But when you're using the results of an experiment to select components for an intervention, you typically have a minimum effect size that is a cutoff for inclusion. And so you only have to power the experiment for that minimum effect size. So if you're saying, for example, I'm interested only in intervention components that demonstrate an effect of 0.3 of a standard deviation, then you power the study for 0.3 of a standard deviation. You see what I mean? You certainly could factor in cost right away, yes. Yes, that would be a really good idea. Okay, a second example. This is a clinic-based smoking cessation study.
Linda,
Yes.
could I just ask one more question about the previous example?
Yeah.
So at the end of that optimization experiment, you will have estimates of effects of the individual components.
Yes,
You will have estimates of the effects for two-way interactions.
yes.
presumably, and then you're going to select the components that you're going to put into the treatment package.
Yes.
Presumably, you could estimate the effect of that treatment package once put together, given the pilot data that you have.
Yeah, so.
And do you do that, and is that used in powering the follow-up RCT to evaluate that package?
Yeah, you definitely could do that. So you would have, it would be based on like a little tiny RCT that would be based on just 70 people, because there's 35 per condition here. But yes, that would give you a great estimate of the effect size going into the RCT. Now, fractional factorial designs, because they don't include all of the conditions, the winning combination might not be represented in the design. So that's one thing to consider. And you would have, but even if you don't have that, you have the individual component effects and their interactions, and that would give you a rougher estimate of that. You still, I think, would have much more to go on to power the experiment than people typically do going into an RCT. Okay, a clinic-based smoking cessation study. 2 more people I'm really fortunate to be working with, Tim Baker and Mike Fiore at the University of Wisconsin. This is a P50. It's funded by NCI. P50 is a center grant. And the idea here is to develop a highly effective clinic-based smoking cessation intervention. So there's some interesting features of this study. It's being implemented in actual healthcare settings. So subjects go to the doctor. They use electronic health records in these systems, and so they're kind of flagged as a smoker. And so that's how we knew to invite them into the study. They were, when they checked in to go to the doctor, they were told about the experiment. As I mentioned much earlier, this experiment involves both behavioral and pharmaceutical components, and of course nicotine replacement is very, very common in smoking cessation work. And we're developing 2 different interventions using 2 different optimization criteria. One optimization criterion is abstinence optimized. That's simply no inactive components. And then cost optimized is the most effective that can be achieved for less than or equal to $500 per person. And it's just a coincidence that both of the ones I'm showing you, the $500 per person seems to be the cutoff. So Baker and Fiore use a phase-based model of the smoking cessation process. Motivation, pre-cessation, which is 3 weeks up to the quit day. Cessation, the quit day to 2 weeks after, and then maintenance, which is 2 weeks to 6 months after the quit day. And I'm going to be talking about an experiment that primarily is in these 3 phases. So these are the components that we're examining. Pre-cessation use of the nicotine patch, pre-cessation ad lib use of nicotine gum. And some of you may be thinking, what's new about that? Doesn't everybody get nicotine replacement? Yes, everybody gets nicotine replacement, and everyone in this study did too. They got it on the quit day. So here, the question is about pre-cessation use of nicotine replacement. Pre-cessation in-person counseling, cessation in-person counseling could be minimal or intensive. Cessation phone counseling could be minimal or intensive. And then maintenance medication duration could be short, which was 8 weeks, or long, which was 16 weeks. So those 6 components were examined in a single screening experiment. In addition, there's another screening experiment I'm not going to show you that examines 5 components aimed at maintenance primarily. So we're actually examining 11 components aimed at pre-cessation, cessation, and maintenance. There was also a 3rd screening experiment examining 4 components aimed at motivation for smokers not ready to quit. So most as implemented in the smoking cessation study. So here are the 6 components. Again, we did a component screening experiment. Abstinence optimized was one criterion. And then the other criterion was cost optimized. And just, we've talked about this a little bit, just to note that we're only doing, it's data from the same screening experiments that will be used in both optimizations. You don't need to do an experiment again. And our funding goes up to here. we currently have applied for funding to do the RCT and some other stuff. So this is a comparison of the different design options. 5 individual experiments would have been over 3,000 subjects. Comparative treatment study, about 1,800 subjects. And the factorial experiments would be about 512 subjects, and that's across all of the experimental conditions. This is the complete factorial would be a 2 to the 6th factorial experiment. The fractional factorial would be 8, 16, or 32 conditions, depending on which design you chose. And we chose a fractional factorial design requiring 32 conditions. So this is the design. I know that it's hard to see like this. In this design, the main effects are bundled with 5-way interactions, and the 2-way interactions are bundled with 4-way interactions. So about implementation, some of you may be wondering, how do you conduct, this was 3 factorial experiments simultaneously. I showed you just one of them. In real-world healthcare settings, with a total of, this was 80 experimental conditions in the field simultaneously. Very carefully is the answer. It takes careful planning and organization, extensive use of computers, and enough well-trained staff, but it can be done. It can be done. We've pulled it off with very, very few snafus. And that's a tribute to Mike and Tim's organization. Status of the smoking cessation project. All the subjects have been recruited and assigned. We're completing data collection and preparation. So we're very, very close to being done collecting all of the data. So altogether, we'll have data on 15 intervention components. There's the 11 in the cessation phases, and then 4 components in motivation. It was 3 separate component screening experiments, as I said, 80 conditions and 1,700 subjects altogether in the 3 experiments. So after we've optimized and evaluated this intervention, we will have set a bar for clinic-based smoking cessation interventions, and future work by us or others could attempt to develop an intervention that is as effective but costs less. Maybe that still costs $500 but is more effective. Maybe raising the cost and going for a more effective intervention, or as effective but less burdensome, for example, or any other optimization criterion that you can think of. And again, this is more about the continuous optimization principle. Okay. So I've talked about a few definitions about behavioral interventions and intervention components. I've described what's business as usual and contrasted it with the multiphase optimization strategy. We talked about the difference between optimization and evaluation. Both are important. We've talked about the resource management principle and the continuous optimization principle, and I showed you 2 examples of this work in the field. So now I'd like to ask you to imagine a few things. Imagine these optimized interventions. An internet-delivered intervention to prevent drug abuse in NCAA athletes, optimized for effectiveness. This is currently funded by NIDA. I can talk about that a little more if you're interested. A brief clinic-based intervention to reduce HIV risk behaviors in MSM, optimized to be the most effective that takes under 6 minutes to deliver. An intervention to increase compliance with a cancer treatment regimen, optimized to be the most effective with the least cognitive burden. A workplace-based intervention to reduce sitting time, optimized to be the most effective while being least disruptive to productivity. An intervention to get arthritis patients to maintain moderate physical activity, optimized to be the most effective that can be delivered in a single 1-hour session. An intervention to improve control of symptoms in end-stage heart disease, optimized to be the most effective for less than $300 a patient. And many, many more. There's many, many more possibilities, of course, almost an infinite number. Now I'd like to ask you to imagine the state of the art if most were widely implemented. So suppose that every evidence-based intervention is optimized, So we know it's the best possible, given constraints. Interventions are engineered with clinically important outcome criteria, efficiency, economy, and scalability in mind. So that every evidence-based intervention that ends up being successful is immediately scalable. It's scalable because important constraints that come up in implementation have been included in the optimization criterion. It's known which intervention components work, so our interventions are transparent. We know which components work. We know what's inside the box. And a coherent base, therefore, of scientific knowledge is accumulating. We know what works and what doesn't, and people can start to build on that. Once a component screening experiment has been conducted, the ANOVA is made public. There shouldn't be any human subjects issues with this because it would just be the results of the analysis of variance. And so others who would like to can optimize using a different criterion if they want to. Many fewer RCTs end up showing null results. If after the optimization experiment, the screening experiment, if you really have nothing, at that point you would not go to an RCT. You would go back to the drawing board. And people would know what hadn't worked. Suppose the resource management principle is used, and every NIH dollar yields the most scientific information obtainable, because the design has been chosen with that in mind. Imagine that every time a behavioral intervention is optimized, a clear bar is set for effectiveness, efficiency, and economy. And any new intervention has to demonstrate that it's incrementally better than the preceding one, and specifically in what ways. In this way, the bar would be raised with each new evidence-based intervention. So there would be incremental progress over time, and interventions would steadily gain in public health impact over time. Let's go back to the gap. Every year, 443,000 deaths in the U.S. due to smoking, 400,000 deaths due to poor diet and inactivity, 35 million deaths worldwide from non-communicable diseases that stem primarily from behavioral causes, and so much more additional morbidity, mortality, and economic loss that's directly or indirectly due to behavioral factors. Imagine closing this gap. Imagine closing that gap, and I think it's possible. Behavioral interventions can be engineered to meet specific criteria. This will set a bar for effectiveness, efficiency, and scalability, and we can then keep raising that bar and gradually close the gap. Thank you.
Thank you, Linda. Very provocative and an important talk about the power of factorial designs in action. I'm very excited to see the examples and look forward to the results pretty soon, at least from the Baker
From the
and Fiore
Wisconsin study, yes.
project. It seems to me that one of the key issues in the optimization strategy is the selection of your components for testing. So I was, particularly in the smoking intervention, I was curious that they only chose nicotine replacement and don't include bupropion or varenicline, and I'm wondering, you know, what will happen? I mean, that's a clear decision for practices. How will we weigh in those standard medical practices against this NRT-based system? And similarly, whenever you have sort of an intervention that's just completely outside the range of what's tested, what's the next step, and how do you decide which ones to include and not include?
Yeah, that's a great question, and of course, you very often can't include all of the components that you might be interested in. So there's a lot more to MOST than I've been able to show you in this talk. One of the stages of, or steps of MOST involves developing a theoretical model of the process that you're trying to intervene on that then enables you to show where each component is expected to intervene. And that is, that's where the components come from, or at least how the decision, a large part of how the decision is made to include various components. In an intervention that already has a number of components, and you want to look at some of the components but can't look at all of them, I often recommend that people take the components they're not varying and just give those to everybody. So everyone can get kind of a core intervention. That's actually what we're doing in the opt-in study, but it's more because our study is about, it's more about compliance or adherence than it is about the actual intervention in this case. But you can take any components that you don't want to vary and just everybody gets those, and then you can vary the other components kind of around them.
Yeah, other as an observation, it's as your sample size diminishes by something like 80%, that is a remarkable example of how we could spread our now scarcer resources further. So thank you.
Yeah. Well, you know, if you're doing a factorial experiment, once you have the subjects, to add another factor very often doesn't require any additional subjects. Now, it would require additional experimental conditions, so I'm not saying it's a decision that should be made lightly. But I think it's something important to consider. And as more and more people are experimenting with internet-delivered interventions, very often the logistics of delivering a lot of intervention components is greatly reduced. It mainly becomes a programming issue. And once the programming is done, it's not difficult to conduct an experiment with many conditions.
Thank you for a great talk. A couple of questions. I'm interested in how the two studies that you described in some detail, and you said both were funded as R01s.
No, the Wisconsin study is a P50.
P50, but it's one of the projects within the P50.
Yes.
Yeah. So it's like an R01.
Yes.
Yeah. So I'm interested in what the experience has been in terms of how much time going through the process that you described takes relative to the follow-on study, which might be another R01, to do the RCT to evaluate the package. So is the first step, the optimization step, a lot shorter, the same length? So I'm interested in that. And the other is, what's the outcome that you're measuring? Is it going to be the same as the outcome in the RCT that's going to follow, or is it an intermediate outcome or something else?
Yeah, those are actually related questions, I think. So about how long it takes, as you can imagine, it's highly variable depending on the context and what area we're talking about. So the opt-in study and the Wisconsin study, these are both essentially clinic-based studies, and so people have to trickle in, and so that's sort of the limiting factor. It's the subject trickling in.
My question is not absolutely how long does it take, but rather relative to the follow-on RCT.
Oh, the follow-up. Okay, yeah.
Does it take any less time, any more time?
Okay, so it depends on whether you want to optimize on the actual outcome, which in the case of smoking cessation is pretty easy to do. And in weight loss is also doable. In drug abuse prevention, it's probably not doable. So in drug abuse prevention, typically the intervention is delivered in 5th or 6th grade, and then the end outcome is more like 10th or 11th grade, and you really can't wait around for 4 or 5 years for that. So the best evidence-based behavioral interventions are based on mediation models. So the intervention components don't operate directly on the outcome of interest. Instead, they operate on mediators, and the mediators are hypothesized to have the proximal effect on the outcome of interest. And so my recommendation to shorten the process in cases like that would be to optimize using measures of the mediators as short-term outcomes, because that is what the intervention is intended to do. It's intended to have an effect on the mediators, and then the baton is handed to the mediators, which then in turn affect the outcome. And if you do it that way, then you have shorter-term outcomes you can use for optimization, and then when you do the RCT later, you would of course use the longer-term outcome. Yeah. Oh, there's someone. Just a minute. There's someone up there.
Yeah. So yeah. First of all, I found this talk very persuasive. I thought it was really, really good, and so congratulations to that. It was, I think,
That's what I was going for.
most of us, yeah, I think most of us agree with it. And, you know, I know that you're a good experimentalist, so I'd like to push you a little bit because, again, I think this was very persuasive, but if I look at what we're doing here, I see us actually going in a different direction. So what you hear a lot about now is using big databases, you know, playing on there being a lot of natural variation in the way that healthcare is practiced. Lots of things are happening all over the place, and the argument's being made that, well, if we just get big electronic databases, electronic medical records with hundreds of millions of cases, and we play on natural variation and use these linear programming approaches to optimize, we'll get the same answer, and or maybe even a better answer. And I was just curious, as an experimentalist, where along that continuum do you start getting nervous?
Well, I feel that, first of all, I don't see it as an either-or thing because the big data out there, I believe, can be tremendously helpful in informing the kinds of experiments that I'm talking about doing here. I'm not sure, though, how helpful big data can be in telling us whether a particular intervention strategy in the form of a component that's intended to move a particular mediator can work. I think that I think those analyses can be tremendously helpful in helping us to see what the mediators are and what we should be moving. But I'm not sure that they can really tell us that a particular, for example, a particular set of lessons in a school-based intervention is going to persuade kids that fewer kids their age are using drugs than really are. So I see them as being different, somewhat different. Now, my colleague Susan Murphy and her collaborators have been working on ways of using machine learning to analyze the data from certain kinds of randomized experiments to get sort of even more information out of the randomized experiments. And that, I think, is an area that has a lot of potential. So I feel like things are kind of dovetailing in that way. Does that answer your question?
Yeah, I mean, so first of all, I think that was a really good answer. I think that you need to keep making this point, that in fact, you might have greater efficiency. I mean, using fractional factorial designs, even with smaller fractions, you know, down into the, you had half fractions, but if you even get down to the 1/16 or so, you actually might be able to get answers to questions actually in a more efficient way than a lot of the directions that others are going. But I like the idea of the two approaches dovetailing.
Yeah, certainly experimentation gives you a less ambiguous answer. I mean, if you just really need to know, does this work? An experiment can be a great way to just answer that simple question. Oh, Carol.
Yeah. Again, I agree with everybody. Very articulate, very persuasive set of points. And in the spirit of implementation, feasibility, and how you actually implement the optimization strategy in our science, I'm going to ask a practical question, especially in reference to the R01s that were funded. And what was the process of getting through the review committees and I guess being articulate and convincing with them about the virtues of the optimization strategy?
Yeah, so the biggest obstacle very often is a lot of people who have been trained primarily in the RCT have some fundamental difficulties with the factorial experiment. They sort of don't believe that it's not a multi-arm RCT. So if someone is proposing an experiment with 16 experimental conditions and you see it as a 16-arm RCT, you would just simply not believe that it could ever be powered. And so we've run into that a couple times. I've gotten better, I think, at helping people to persuade review committees about that. It's hard to do it in 12 pages sometimes, but I've been working on concise ways to phrase that. And in fact, if anyone's interested, that's gone, but if anyone's interested and looking at my website, I have some information there for people who are writing grant proposals using MOST or using factorial experiments, and some wording I've used that seems to be clear and has persuaded people in the past, and people are welcome to take that and adapt it for their own for their own needs. The opt-in experiment was very well received by the committee. They really seemed to resonate to the innovative aspects of it. So, you know, it's, I feel like we're starting to have more success. I've also been trying to publish articles that cover this material and try and clarify some issues about MOST and about factorial experiments. And of course, I'm learning as I go. You know, MOST is an open research area, and not every question has been answered with respect to MOST either. Right now, NCI, NIDA, NIDDK, and NIMH are all funding one MOST experiment that I know of. NIDA is actually funding two. So things are maybe starting to pick up steam, I hope. Oh, I'm sorry, John and David.
So just as a follow-on to that question, not to be too review geekish, but there's no proof of concept yet, right? So no preliminary data to suggest that this works.
Yeah, that's true. That's a good point. There isn't, yeah.
So
That's right.
I think a special mechanism developed around this would be a better way to go than, you know, just because it can be shot down technically.
Yeah, that's true. Yeah,
That's not completely true. There's a nice paper just out in Addiction showing a design very similar to this, a factorial design by Dave Gustafson, so also from Wisconsin, just
Okay.
published this month. So there's
great,
at
I'll
least
have
something, it's not exactly the same, but it's could be used to help justify it.
Yeah, actually, there are a couple of, so there's not a proof of concept of MOST from start to finish, it's true. But there are a couple of examples besides that one of large factorial experiments. There's Vic Strecker published an article that I was an author on, and a host of others in 2008. And then there was another one just last year that was also in the smoking area, another fractional factorial design. So both data-based, both reporting results. So there's starting to be some. So that's a fair criticism, though, because it's right. There's not a lot of proof of concept at this point.
Just curious what the study sections were that reviewed the couple that you've been involved in, if you remember.
Yeah, because it's my first NIDDK, there was an acronym for the study section, but I know I'll get it wrong, so I think I'd better just not say it. For NIDA, for the NCI study, it was sort of a weird set of circumstances. It actually, Mike and Tim had a T-Turk, and the T-Turk mechanism was stopped by NIDA, and they were encouraged to put in an application for a P50. And so we put in an application for a P50 that was kind of centered on MOST and to do the 3 experiments that I told you about. And it got a good but not fundable score. And then we actually had written the revision, and we were days away from submitting it. And then NCI contacted Mike and said that they were interested in funding it if we made some changes. So they were just very taken with the innovative nature of it and saw it as a real hope for doing something different in the cessation area. So that was kind of an unusual situation.
One of the questions that came up at the physical activity workshop that the Office of Disease Prevention sponsored in December was, how do we find ways for NIH to support intervention development? And this approach that you've been describing here is one such way that could be used. You've done it with a couple of R01s. Granted, it's not necessarily an easy sell to the study sections, and they're going to have the right sort of methods people in order to appreciate what's being proposed. But that could be, this is an excellent way of doing what I think of as the intervention development activity before you're ready to launch the full-blown RCT.
Yeah, and I want to stress, by the way, that if it wasn't clear, that these experiments are not pilot studies. They're fully powered serious experiments.
Right, and that's part of what the reviewers are going to like with an R01 application, because there will be an outcome.
Yes. That's right.
One last sort of, it seems to me that your examples and the other ones I've thought of are really focused on sort of practical clinical trials areas
Yeah.
or implementation science, loosely, broadly defined.
Yeah.
Do you see a role for the most approach in more fundamental intervention development for sort of baseline,
Yeah.
theory-driven?
Yeah, like type 1
Yeah.
translation. Definitely. Yeah, definitely. If you were developing an intervention from scratch and all you really had was the results of laboratory studies or perhaps a meta-analysis, something like that, I think most would be a great way to get started. Yeah, definitely. Yeah, I see it as a good way to do both type 1 and type 2 translation. Yeah, when it comes to implementation, very often people do implementation studies and they're always observational studies. But I believe it's potentially possible to experiment on some of that stuff, and it would might potentially provide some clear answers. Denise?
Hi, yes, Denise again from NHLBI. I just thought I'd comment that if you want evidence that factorial designs are acceptable to trialists, you could cite the ACCORD trial, which is 10,251 people, adults with type 2 diabetes. It used a double 2x2 factorial design looking at events as outcomes.
Okay.
If that's not accepted by the field, I don't know what is. It wasn't behavioral, though. Well, it was, in that they had to adhere to the, it was a drug treatment trial, basically, a drug strategy treatment trial. But
Thank you.
a lot of money spent on that
Yeah.
factorial design study.
Yeah. Well, thank you, Denise. That's really helpful. This has got me thinking that I should have a section on my website on this very topic.
Other questions? Any questions from If we have no other questions, then I think we thank Dr. Collins very much for a great presentation. Thank you all for the discussion.